Right. We are right at 2 o'clock, so we will give Dr. Kiefer a minute to start her slides, and then we'll get started. Thank you for joining us today for our MPRINT webinar. We're proud to host two of our Opportunity Pool awardees from year one. Miranda Kiefer is a maternal fetal medicine fellow from Ohio State University, and Dr. Rood, who is a maternal fetal medicine faculty from Ohio State University, will both be presenting on their work today that they've been working on as part of their Opportunity Pool funding. So we will start with Miranda, who is going to be talking about frequency and dosing of nifedipine in women with severe preeclampsia undergoing expectant management. As always, we invite you to ask questions through the Q&A or at the end of the session after both Drs. Kiefer and Dr. Rood speak. We'll have some question and answer time at that point, and we can, if you raise your hand, we can allow you to speak at that time and ask your question. So without further ado, I will turn it over to Dr. Kiefer.
Hello, good afternoon. As Dr. Quinney just said, my name is Miranda Kiefer. I'm one of the fellows in maternal fetal medicine at Ohio State University. She very eloquently just said the title of my project, which is frequency and dosing of nifedipine in women with severe preeclampsia undergoing expectant management. And as she also said, I'm one of the 2022 MPRINT Opportunity Pool awardees. So make sure, there we go. Just to give a little bit of background about preeclampsia, this is something that is very well known to all obstetricians across the world. It's a very common thing that we encounter. About 1 in 25 pregnancies are complicated by preeclampsia. It is the second leading cause of maternal mortality worldwide. This is following the first leading cause, which is maternal hemorrhage. It can lead to maternal complications such as stroke, eclampsia, which is seizures, or organ failure, which is typically liver or kidney. And it can lead to fetal complications as well, such as iatrogenic preterm birth. This is usually in the setting of a maternal preeclampsia disease that is so severe that we think it's too dangerous to continue pregnancy. And so we do a preterm birth for maternal reasons. It can also lead to growth restriction and low birth weight. And both of these are typically in the setting of what we think is placental insufficiency. We think that preeclampsia probably originates from some dysfunction at the very early parts of pregnancy within the placenta that can eventually lead to dysfunction and growth restriction. So in terms of the diagnosis, we diagnose preeclampsia. Usually the mainstay is by blood pressure, and you can have mild or severe preeclampsia based on these, but any systolic blood pressure greater than 140 or diastolic greater than 90 would be concerning for preeclampsia, but this does typically need to be replicated due to a lot of issues with reproducibility if there's like white coat hypertension or inaccurate readings or cuff issues, and then preeclampsia usually, not always, but usually should be coupled with proteinuria. And this is typically measured by having 300 milligrams of protein in a 24-hour urine collection, or as we usually use due to just the ease of collection, a spot urine that has a protein to creatinine ratio of 0.3 or more. However, we do think that preeclampsia is now more of a spectrum and can present in a lot of variable ways. And so even without proteinuria, if you do have other severe features that would not really have a good explanation otherwise that can support a diagnosis of preeclampsia, this could also give you that diagnosis. So those would be the severe range blood pressures, the systolic greater than 160 or diastolic greater than 110, or severe lab abnormalities such as low platelets or thrombocytopenia, impaired liver function, renal insufficiency, pulmonary edema, or severe symptoms like a refractory headache or visual changes. The management of preeclampsia is expectant until usually the gestational age of 34 weeks. The reason this is chosen is because at this point we know that the fetuses typically do very well. This is a late preterm delivery, and so babies are, very mature usually and can resuscitate very well. And the ongoing risks of mom being exposed to the preeclampsia are too high at that point. and patients are hospitalized until delivery. The mainstay of treatment during this time period is basically monitoring blood pressures and treating if it's greater than 160/110. There's a couple of different methods for treatment, short-acting medications, which would include IV labetalol, IV hydralazine, and immediate release nifedipine. The short-acting medications are good because it brings down those dangerous blood pressures quickly, but typically you only want to titrate that blood pressure down by about 25%. But in about 10% of women, it actually does cause a higher decrease than that and causes maternal hypotension that can lead to fetal distress. And as you can imagine, can lead to an iatrogenic preterm birth, typically earlier than that goalpost of 34 weeks. And so the more stable way to treat blood pressures, if you're not trying to get people out of that dangerous territory, is long-acting medications. And this is typically with long-acting nifedipine, oral labetalol, and oral methilopa. Unfortunately, although we have kind of the treatment strategies and the medications that are used, there really is no guidance or head-to-head studies looking at which medication is the best, how frequently to dose them, what doses to use. And there's really no guidance on what the optimal thresholds are for treating blood pressures during pregnancy. In part of doing this project, we did kind of poll the maternal fetal medicine doctors here at our institution and nationally. And then there does seem to be kind of an expert opinion cutoff of initiating and titrating those long-acting medications once that blood pressure is over 150/100. And the goal of this would be to decrease the acute events where you're in that severe category and needing the acute IV or immediate release treatment that can then subject the mom to hypotension and fetal distress. Interestingly, the CHAP trial was published in the last year. This was a randomized control trial at multiple centers across the country put on by the MFMU. And they actually looked at active treatment of blood pressures to under 140/90 in those who had a diagnosis of chronic hypertension in the first trimester versus not treating blood pressures and just kind of seeing where things go. Obviously, if blood pressures get really high, working people up for preeclampsia. And they found in those who had active treatment and did have their blood pressures titrated to a more suitable range, there were lower rates of preeclampsia and preterm birth. And so this is importantly not done in a cohort of women with preeclampsia, but it's, interesting that this study kind of supports what we have been behind the scenes kind of doing in terms of treatment of these patients. In terms of the medications, I said the long-acting medications people use are nifedipine, labetalol, and methyl-dopa, but this study particularly focuses on nifedipine. There's unfortunately no guidelines on the optimal dosing or frequency of that in pregnancy as well. There's very limited data on pharmacokinetics of nifedipine, and this is limited to the short-acting forms as used in tocolysis, as nifedipine is a calcium channel blocker. It has also been used to stop contractions and decrease myometrial preterm contractions. In those studies, they did find that the half-life was longer, 3.4 hours versus 1.3 hours in the non-pregnant people. In non-pregnant people, though, when you look at the extended release formulation, it's supposed to be released at a constant rate for 16 to 18 hours with a Tmax of 15 hours. And this really does make it a good medication to be dosed every 24 hours. However, with this limited data of nifedipine, especially this XL formulation in pregnancy, there's a lot of variation in practice, and there are many physicians across the country as well who dose this medication twice a day, just due to the theoretical increased thinking that there's probably increased clearance during pregnancy like there is for so many other medications. So the mechanism of action of the XL formulation is a gastrointestinal therapeutic system, or a GITS. This means essentially that it's an osmotic pump within a semi-permeable capsule that slowly allows water within the bilayer core. As the tablet absorbs this water, the osmotic pressure lets out small amounts of drug over time for a steady rate for approximately 24 hours. Now, understanding this mechanism of action and then thinking about the physiologic changes of pregnancy, I think it's important to note that women who are pregnant have a delayed gastric emptying time. This is due to the elevated progesterone levels in pregnancy that delays smooth muscle contraction. And so perhaps pregnant women have this GITS system in their gastric cavity for longer than non-pregnant people. However, there is still an increased volume of distribution, increased renal elimination during pregnancy. However, we don't think this is cleared renally, but there's also upregulation of the CYP3A4 enzyme in pregnancy, which is the main enzyme that metabolizes this drug. So the primary aim was to compare the rates of suboptimal blood pressure control in pregnant women undergoing expectant management for preeclampsia with severe features that are initiated on nifedipine 60 milligrams extended release once daily versus nifedipine 30 milligrams extended release twice daily. The secondary aim, which is the MPRINT funded opportunity portion of the study, is to assess the mean plasma concentration levels of nifedipine XL when dosed either daily or BID over a 24-hour period. Our hypothesis was that among women with preeclampsia with severe features who undergo expectant management, nifedipine 30 twice a day improves blood pressure controlled compared to nifedipine 60 milligrams once a day. The study design is an unblinded randomized controlled trial in patients who are admitted for expectant management for preeclampsia with severe features, which is standard of care both in our center and across the country. And as I said in the beginning, this expectant management continues until 34 weeks. Patients will be enrolled once the decision is made to increase their daily dose of nifedipine XL 30 to 60. Just due to the study design, we can't enroll these patients until that increase happens because we can't really split the dose of 30. And so by using that daily dose of 60 milligrams, we're then able to divide them into those two groups, which is either 30 in the morning and 30 at night, or just 60 in the morning. The primary aim is to assess the frequency of suboptimal blood pressures. And based on just expert opinion across our institution, this would be a systolic blood pressure greater than 150 or a diastolic blood pressure greater than 100. And so we will compare the percentage of suboptimal blood pressure events calculated over the 24 hours after the regimen increase and compare between groups. Importantly, that 24-hour period happens after 1 day after the increase has taken place, so that the participants in both groups are at steady state, and so that disease progression is around the same part of the preeclampsia pathology between groups. The secondary aim is to assess a subset of patients who will be co-enrolled and looking at their pharmacokinetic parameters with the plasma concentrations leveled at time periods 0, 1, 2, 4, 6, 12, and 24. So 7 time periods over that day 2 after the increase once they've met steady state. Secondary outcomes are going to be mean blood pressure measurements, duration of expectant management, gestational age at delivery, delivery information, and adverse maternal and neonatal outcomes. The sample size was calculated to be 56 women to demonstrate a 30% decrease in the rates of suboptimal blood pressure control. This was based on a retrospective analysis of internal data. And then based on our resource availability, we had a goal of 20 co-enrollments for the pharmacokinetic study. Currently, we have 67 patients who have been screened. We have 6 that have declined, 11 that were ineligible. Ineligibility is typically because they're on an alternative blood pressure medication like labetalol at baseline, or they were already on 60 milligrams and could not be randomized, or they proceeded with delivery before they could be randomized. We consented patients once they were admitted on 30 milligrams of nifedipine daily. It's pretty standard of care at our institution if somebody gets admitted for severe preeclampsia, especially in the setting of elevated blood pressures, to initiate them on nifedipine 30. So most women who do get admitted to our service for this can be approached for consent. So we were able to consent 50 patients, and then kind of there's that drop off because we can't enroll them unless their physician has made the decision to increase them to 60. And the decision to increase is a clinical decision. It's not part of the research protocol. And it typically follows either multiple elevated blood pressures that require that short acting medication. Patients will typically get increased, or if there's multiple blood pressures that are over that suboptimal range of 150 over 100, that's when they typically do get increased. And then we've co-enrolled 18 patients into the PK arm. And I will say, hot off the press, as of today, we just consented another patient for the PK and for the main study. So hopefully we will have 19 in the next week or so, just waiting for her to be increased. And then this is just preliminary data from the 18 PK patients that we have so far. Certainly all of these parameters will be evaluated in the entire cohort of 56 women, but just to give you guys a little bit of information about where we're at so far. So the pharmacokinetic parameter study is not going to be randomized for daily and BID, so they're not necessarily going to be balanced because it's just a whoever we can enroll in that portion of the study enrolls. So we have 11 patients in the daily category and 7 in the twice daily, an even number of Hispanic patients. Most of our patients are white with 1 or 2 Black patients in both categories. Most of our patients are class 1 obesity, which is not of a surprise. There's an even number of diabetic patients and patients who had COVID in pregnancy. Interestingly, there's more patients in the daily category who use tobacco and who have chronic hypertension at baseline. And then, just kind of preliminarily, the suboptimal blood pressures of those greater than 150 over 100 were calculated for both groups. They're about a third in both. I would hesitate to make any sort of conclusions about this for both without looking at the entire cohort. And they both have about the same number of need for short-acting medication during that time period with a similar systolic and diastolic mean, as well as similar rates of being delivered less than 34 weeks and growth restriction and birth weight. So that's what we have so far. We're hoping to, I think, finish the PK portion of this just any day now. We just need one more person to walk in the door, and then probably the main study in the next 6 months. And that's all I have. These are my references, and I think we're going to be taking questions at the very end.
All right, great. Thank you, Dr. Kiefer. And we will move now to Dr. Kara Rood, who's an clinical assistant professor of obstetrics and gynecology and maternal fetal medicine at Ohio State University. She will be talking about using exosomes as a pharmacodynamic endpoint to determine aspirin dosing for the prevention of preeclampsia, a pilot proof of concept study. So we'll get the slides switched here. Almost they're using the same computer for slides too.
No, we didn't. We may have to.
There we go. Great.
I think we're ready, everyone. Looks
Yeah,
good.
we see your
All right,
slide.
perfect.
You want to put it in?
Thank you, Sarah, for the introduction. And Miranda and I kind of tag team, so we didn't talk too much about the same stuff, given the commonality of preeclampsia for both of our studies. So to get started, ours here is multi kind of investigators here, and we're all kind of listed at the bottom there. Myself, Dr. Cosentine, Dr. Menon, as well as Dr. Searle. And so getting started,
Dr. Rood, could you put it in
pregnant
slide
patients
show?
are therapeutic orphans, as majority of the pharmacokinetic and pharmacodynamic studies exclude them due to multiple risk factors, including logistic and ethical concerns. Current practices in drug evaluation in pregnancy really lack innovation, are time and effort consuming, not streamlined for novel drug development or repurposing, and are hindered by relying on traditional biomarkers and study designs. Thus, the need to shift the paradigm in therapeutic research in pregnancy by developing novel methods and using novel specific biomarkers in order to assess the response of effects on placental health. Preeclampsia occurs in about 5 to 8% of pregnancies, and it is associated with significant maternal morbidity and mortality. While preeclampsia is thought to be mediated by a failure to establish normal placentation that's leading to uteroplacental underperfusion.
Sorry, I don't think it's showing the normal one.
We're seeing your, it looks like your website.
Oh, please, let me see.
Download. So
Do new share and just open the PowerPoint. Yeah.
Oh, there.
There you go. Much better. Thank you.
All right, sorry about that. Moving on. So while preeclampsia is thought to be mediated by a failure to establish normal placentation, leading to uteroplacental underperfusion or mismatch between placental metabolic demands versus supply, placental hypoxia, and incomplete remodeling of spiral arterioles, there does remain a significant knowledge gap and unmet needs in effective prevention and treatment in preeclampsia for pregnant people. Currently, the only known cure for preeclampsia is delivery of the fetus and the placenta, which often leads to iatrogenic preterm birth. And this by itself is a significant cause of neonatal morbidity and mortality. Currently, the United States Preventative Task Force, the American College of Obstetrics and Gynecology, and the Society of Maternal Fetal Medicine recommend the use of low-dose aspirin for preeclampsia prevention in at-risk pregnant people. This is based on the results of randomized controlled trials and meta-analysis that have shown that low-dose aspirin, commonly defined between 60 milligrams to 162 milligrams per day, started early in pregnancy, reduces the frequency of preeclampsia in at-risk individuals. That includes those who have a higher BMI, of our older age, history of preeclampsia, or of pre-existing conditions such as diabetes, hypertension, renal disease. And this reduction is a relative risk that ranges between 15 to 43%. However, the optimal dose and the mechanism of action are unknown, partly due to the lack of biomarkers to monitor the fetal placental response. Sorry, just 1 second. Nothing seems to be advancing correctly. Okay, dependency on maternal plasma biomarkers to determine placental function or response to therapeutic interventions has not really yielded desirable data that improves pregnancy outcomes. This is specifically true that current biomarkers are not indicative of fetal and placental health. Extracellular vesicles are lipid-bound vesicles secreted by cells into extracellular space, and recent advancements in isolating fetal and maternal extracellular vesicles and characterizing their cargo content may actually help better understand the response to therapeutic interventions. As these extracellular vesicles reflect the physiologic or pathophysiologic state of a cell at the time of their release. In pregnancy, first trimester maternal plasma microparticle proteomic cargo was found to be associated with preeclampsia. And various reports have highlighted the usefulness of placental-specific extracellular vesicles, which are positive for placental alkaline phosphatase as a biomarker for pre-E, as shown here in Figure 1, and demonstrated a potential mechanistic role in causing preeclampsia. Several other studies have provided supportive evidence to show that this placental alkaline phosphatase plus and the extracellular vesicles are valuable markers to predict the preeclampsia. Additionally, work from some of the co-Is here have shown that decreased oxygen tension, a condition associated with preeclampsia, produces a distinct class of extracellular vesicles, microRNA, that can cause placental dysfunction by impacting the spiral artery remodeling, which is thought to be a pathological association with preeclampsia. Although diagnostic potential of exosomes have been reported, no studies have examined the response to these therapeutic interventions, such as doses of aspirin on these exosomes. Aspirin is known to affect the endothelial and trophoblastic cells, thus potentially modulating exosomes derived from these cells, the quantity and the characteristics, and their cargo contents has been understudied. Therefore, we are proposing a proof of concept exosome profiling study to characterize the response of aspirin therapy in patients at high risk for preeclampsia. We hypothesize that the exosomes can be used as biomarkers and serve as a pharmacodynamic endpoint in assessing the response to different doses of aspirin in patients at high risk of developing preeclampsia. Conveniently, at Ohio State, when we applied for this, we had conducted a randomized controlled trial of high-risk pregnant patients that were assigned to 81 or 162 milligrams of aspirin daily. Our specific aims were to characterize the maternal plasma proteome profile in high-risk individuals receiving these different doses of daily aspirin, the 81 or the 162 for pre-E prevention, and demonstrate that the proteome profile from these patients receiving the higher dose of aspirin was more likely to mimic what is seen in a low-risk control group compared with the profile in patients receiving the lower dose of aspirin. Our second aim was to compare the angiogenic and inflammatory biomarkers in high-risk individuals on the different doses of aspirin, and to examine whether these biomarkers correlate with the changes in the maternal exosome proteome profile, as well as clinical outcomes, which included the development of preeclampsia. For our methods, maternal samples had previously been collected, processed, and stored at -80 degrees Celsius from the ongoing randomized control trial. We randomly selected samples from the 81 and the 162 cohort with reported compliance with aspirin, and the samples had been collected between 28 and 32 weeks gestation, which is approximately 10 to 20 weeks after the initiation of aspirin. We then used a matched gestational control of maternal samples that was selected from an already established biorepository. The extracellular vesicles were isolated using multi-step centrifugation followed by ultracentrifugation, size exclusion column purification, and multiple washes to remove the high redundant proteins. Characterization, profiling of their content using mass spec, data processing, and modeling were used for the analysis. So we analyzed the protein cargo present in the maternal plasma extracellular vesicles that were obtained from these individuals. We had 36 individuals in the 81 group, 19 individuals in the 162, and a control low risk group who did not receive aspirin of 7. The mean gestational age for these cohorts was 28.4 gestational weeks, and the rates of preeclampsia were 29% in the control group and 18% in the aspirin groups. So here is kind of our preliminary data, at least for specific aim 1. It shows your extra cellular vesicle characteristics in the plasma, maternal plasma from the aspirin treated and the control subjects. 2A shows the size, 2B shows the shape, and then 2C through 2E show some of these extracellular vesicle markers, which is a CD63, CD81, and CD9. There were no differences between the control and the different groups of aspirin in the different doses, emphasizing the need for significance of the analysis of the actual cargo contents, since the other characteristics were not different. So the next step was these samples were then subjected to standard data dependent acquisition based mass spec using the Scribe it's a novel library search engine that was developed by one of the co-PIs labs. Using this technique, we identified an average of 432 proteins in each EV sample. And this calculated a global FDR and uses like a new approach to kind of interface recognizing a match between run algorithm that quantifies the peptides in each sample regardless of the detection in any specific sample. This approach allowed us to generate a full data matrix across all pilot samples for about 1,230 total proteins. We found 14 markers that track with aspirin dosage, including 5 proteins in the androgen signaling pathway, ADAM10, CD47, FERM-T3, as well as ITGA2B and ITGB3 were involved in the mediating cellular response to binding molecules in the extracellular matrix. And other significant proteins that we found included the coagulation factors FA7 and FA9. So for our conclusion, we found that these data indicate the robustness of the extracellular vesicle proteomic signature as predictive markers and demonstrate that our methodological approaches and analytic capabilities in this profiling of the extracellular vesicles was indeed successful. And for future directions, applying for funding to isolate maternal and fetal EVs from the maternal plasma and really test the hypothesis of the differential expression of the EV proteome cargo and see its association with placenta and pregnancy health in response to aspirin treatment at different gestational age periods. And then also with hopes to provide an opportunity to develop a resource that can really eliminate biomarker-related barriers in conducting therapeutic research in pregnancy. And I think that is it.
Great. Thank you both very much for your excellent presentations. We do have one question in the chat already, and I will invite others. If you have questions, please add it to the chat or raise your hand so that we can address it. The first one is to Dr. Kiefer. How was compliance assured in the daily versus twice daily nifedipine study?
Sorry, we're in the same room, so we're having feedback. So all of the patients who are enrolled in the nifedipine study are admitted to the hospital, which is standard of care once you have severe preeclampsia. So all of the medication is doctor ordered and nurse administered. And so, I mean, theoretically, there could be patients who are refusing medications. And certainly when we go through all the data, that's something that we'll be taking note of, missed doses. But I will say preliminarily, the 41 charts that I've looked at, nobody's missed any doses.
All right. And then was there an assessment of trough peak ratio for the blood pressures? So standard for blood pressure control of daily dosed hypertensives.
I don't have that data pulled out yet. Some of these patients, it's going to be kind of a long haul to go through because some of them do have like 24 blood pressure measurements in one day if they're getting multiple doses of medication. But that's certainly something we can look at. And, you know, I'm hoping that once we get the plasma concentration data too, we can do some sort of correlation with what the blood pressures were versus what the serum or the plasma concentrations were.
Great. All right. So Dr. Rood, I don't see any other questions, but I do have, you know, some thoughts or questions for you as well on the ability for the exosomes and what you're finding is. So you found 14 markers from the integrin and the coagulation pathways. Have these been shown in previous studies to be associated with preeclampsia?
So we're still investigating some of that there. This is pretty new data, definitely something for further areas of interest. And I think even in a larger sample to kind of ensure that all of these are correlating with it.
Great. And then, so you're, for your extracellular vesicles, are these specific to maternal, fetal, placental, or are they just whatever is in plasma? So
no, we're actually looking at specific placental ones, and you can compare them to maternal ones, so you can identify them from different sources. So really, okay. I think when we started, we went more like broad with maternal, with hopes for future funding to also compare maternal and placental and look a little bit more at placental focused ones as well.
Great. Are there any other questions from the audience? Feel free to raise your hand or input it into the question and answer box. So I will have to say for Dr. Kiefer, I'm excited to see what the data on nifedipine shows and get that PK data to actually look at and analyze and compare to our prior data of immediate release nifedipine in patients.
So excited. We just got that one more today. So now I'm like very excited. We just need one more after that.
It'll be nice to know the answer and not what everyone just thinks.
Yeah, it's funny. It's one of those, I mean, I feel like you find these things more and more the more you practice, but there's like a lot of things that like, at least as a resident, you feel like you're like taught it as gospel and you assume there's so much data to back it up, but like slowly you uncover a lot of these clinical decisions really have no data. So it'll be interesting to see.
All right. Great. Well, with that, I don't see any additional questions, so we will go ahead and close our webinar today. I thank you both for presenting and for contributing to the MPRINT Hub through your Opportunity Pool Awards. As we will mention also that the Opportunity Pool funding is open for year 3 requests for funding. I will drop that link in the chat as well. It's available on our website. So please, if you have projects relating to maternal and pediatric therapeutics that you think are eligible for these funding resources, please reach out to us. Thank you, and we will see you all later.
Thank
Thanks.
you.
Bye.